I'm Peggy Ty. I work with CV340B, and I'm joined by my co-lead in this venture, Rhiannon, who I will let introduce herself.
Hi, everybody. My name is Rhiannon Klein. I am our National Advocacy Manager for Community Voices for 340B. Thanks for hanging in there with us as we kind of navigate some of our technical difficulties this morning. Bound to happen to all of us, so we appreciate that. With us this morning is also our Texas Field Director. I know Texas is not in the Northeast, but we wanted to introduce him anyways. He is a part of our staff, John Reed. He is joining us from Texas this morning.
We have three awesome panelists today. I'm Fiorella Sandana, is a 340B Pharmacy Program Manager at St. Joseph's University Medical Center. Got Renee Mosier, Director of Pharmacy at Porter Medical Center, and Nicole Coney-Beer, who is a Pharmacy Program Administrator at Cornerstone Care Community Health Center. Thank you very much, ladies, for joining us and talking about the benefits of the 340B program and how it works in your community. Moving on. Rhiannon, you're muted. So we'd like to do now is play a video for you. And this video is a great little explainer, try that again, explainer of the 340B program. So we've used this now actually for several years, and we've heard a lot of great compliments about, boy, this makes it make all the more sense in the world of what 340B is. So if Rhiannon, can you share screen and show that?
What is 340B? To find out, let's go back to the early 1990s. Money was tight, as it always is, and it was a difficult time for America's safety net providers, those providers treating large numbers of poor and uninsured patients. So as part of the Bipartisan Veterans Healthcare Act of 1992, Congress created the 340B Drug Pricing Program. The 340B program allows qualifying safety net providers and certain qualifying hospitals to buy prescription drugs at discounted prices from drug makers. As Congress stated, the goal of the program was to enable these entities to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. And since 1992, that's just what 340B has done. Let's explore how 340B actually works. Here is a small clinic in Ohio that participates in the 340B program, and two of their patients, Bob and Tina. Now let's say a 1-month supply of a diabetes drug costs the clinic $1,000 from a drug maker. Tina has private insurance, which pays the clinic $1,100 for her medication. Now, Clinic A has $100 in income, but with 340B, the clinic can buy that same drug from the same drug maker at a special lower price of $600. With 340B, the clinic still gets paid the $1,100 by Tina's insurance, but the sale now generates $500 in income, which the clinic must use towards its expenses. Now, along comes Bob, another patient at the clinic. Bob doesn't have insurance, but he needs medication too. Fortunately for Bob, the clinic now has that $500 in 340B savings to help pay for his treatment, and that $500 hasn't cost taxpayers anything. Without 340B savings, many clinics and organizations would have to find new money to stay open, most likely from taxpayer dollars. Either that or the clinic might be forced to send away patients like Bob, and those patients go untreated. Or worst of all, the clinic could close down altogether. But thankfully, clinics and their patients thrive with 340B because it allows clinics to offer better means of treating and keeping patients in care. The 340B program is already well regulated by the Federal Health Resources and Services Administration, which established rules that manufacturers and providers must follow to participate in 340B. Congress also keeps a very close eye, and 340B safety net providers and hospitals are subject to oversight, monitoring, and regular audits. Smaller safety net providers like Ryan White clinics who treat patients living with HIV/AIDS are concerned because the mechanics of 340B are often questioned or reevaluated by lawmakers and challenged by drug makers that would rather sell their products at a higher price. The truth is, this small program that does a world of good only accounts for 1.3% of all drug purchases in the U.S. We want to protect the vital assistance 340B gives to Ryan White clinics and all safety net providers. 340B has been working as intended for safety net providers and their patients for over 25 years. And that's why we'd like Congress and elected officials to simply let it be. To get involved and find out how to protect 340B, visit let340b.org.
All right, so moving on to the next slide. So I think that was a great overview, and thank you for the person who put in chat that they thought it was a great video. It's a touch dated. Some of those figures for the pharmaceutical company profits are in dispute right now, but we know it's under, at very least, under 10%, probably more like under 5% of total pharma drug gross profits. So it's still a modest amount that pharma is contributing to the safety net in exchange for getting a giant market of being able to sell their drugs in federal programs. So we know it was established in 92. We know that this is the trade-off. My favorite story is that, and I was here in 1992, but I wasn't involved in 340B yet, is that two senators got together, one very conservative and one very liberal. And the liberal senator, Senator Kennedy, said to Senator Hatch, hey, drug prices are going through the roof. What is happening here? We got to do something. Let's put price controls on drug companies. And Senator Hatch said, nope, not how I roll. That's not how conservatives want to handle the pharmaceutical industry. I've got a better idea. Why don't we sit together and come up with a program? And they did. And that program is the 340B program, which I think I know it's unique, and it's a very rational way to make sure that drug prices are lower and those savings are translated back into the communities through the covered entities. So most of you already know that about 340B, but I think it goes without saying, but most important is without taxpayer funding. This is directly through the drug manufacturers. So we have these great little snippets all over CV340B's website that can give you this short little rundown of what is 340B, what is the history, what is it today, and who are we and what are we trying to fight for. CV340B realized a couple of years ago that what was absent from the conversation was the patient voices, that people, number one, didn't know there was a 340B program. Number two, had no idea how it was helping them in their communities. And number three, had no idea it was being threatened by drug manufacturers who were trying to shrink or remove the program altogether. And that's where we came in. So most of you probably know that health centers, hospitals, and specialized clinics are the quote unquote covered entities under the 340B program. In recent years, we've kind of realized there's a better way to talk about this whole group, and that's safety net providers. These are all, without question, safety net providers. Why did Congress pick all of these entities to benefit from the 340B program? Is because they're safety net providers. They do something unique. They do something special. They care for specialized populations. They care for disproportionately more Medicaid or more Medicare patients. Congress picked all of these groups. So when you hear from the other side, oftentimes pharma, the trade association for drug companies, they'll tell you that there's been explosive growth in the program. Part of what they point to is the addition of more covered entities. Well, Congress did that. Congress did that decidedly on purpose, because they wanted more of these organizations to benefit from 340B. So I think just taking a quick look at this, you can understand the public good that's involved in all of these kind of entities that are subject to oversight, audits, and the like. So I hinted at the threats to the 340B program, and these are the what we call trade associations or national associations for drug companies. Pharma and bio are the shorthand terms for those groups. They have spent almost a decade trying to roll back what we think is their responsibility to make sure that these savings end up in the communities, as opposed to, well, just a higher price for drugs with the manufacturers. One of the ugliest moments until last summer was back in 2017, 2018, when Congress was taking a hard look at the 340B program at the behest of pharma and bio. And they tried to make major changes to 340B that we believe would have eviscerated the program. So when I say we, those covered entity groups got together, particularly the grantees, also the hospitals, and we fought back like hell, pardon my French, and said, no, 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 wrong way to go. Why would you be hurting this program when it is doing so much good? In more recent days, what the drug manufacturers started on a path toward, not all of them, but some of them, is to try to change the program themselves. And this is in the context of contract pharmacies. So one element of the program that was meant to get more access to more drugs to more people, they attacked and said there wasn't statutory authority for anybody to do that. So they, in my opinion, rewrote the rules. It's also not just my opinion. HHS and HRSA has now jumped in and said, no, no, you've overstepped your bounds, these particular drug manufacturers, and we are finding that you must pay back all of what you took away from the 340B covered entities. That just happened just a week or so ago in a letter from HHS, of course, is Health and Human Services. The undergroup, if you will, is Health Resources Services Administration. The letters to drug manufacturers came from HRSA, and HRSA said, stop and desist. We have been waiting for this since this administration came in, and we waited not so patiently for some of us 5 months before that was released. And now we're waiting for the courts to sort it out, and hopefully we will have victory. In the meantime, it's a bit of a waiting game. You don't want to hear all the details of it, but we can give you more if you want it outside of this call. But we have really good first indication that this administration is going to stand for, behind, and with 340B. So also not just the drug manufacturers are after us, but the insurers and some PBMs are after the 340B program. They want to take our savings. Our friends in the FQHC world, which is the community health centers, have termed the term pickpocketing. That these are for-profit entities that are taking money away from the safety net. We've called it more formally discriminatory reimbursement, that they treat 340B entities differently. So an insurance company goes to a covered entity, a safety net provider, and says, here's your new contract. In the contract, it says, we're not going to give you that 340B savings. What? How did they get to make the rules? They're not even in the 340B program. So many of you may have noticed in the last 2 years, really, there's been a dozen, almost 24 states who have tried to advance in their legislatures. Some have been successful. A lot of them have been successful to establish a prohibition against discriminatory reimbursement, to not let these insurers and PBMs take the savings out of the covered entities and therefore out of your communities. So we're fighting that fight. And just for fun, I guess, the states are also coming after us. And this is in the term of carve out. And the carve out is a technical policy term for moving the pharmacy benefit of Medicaid from one way of functioning to another way of functioning. And what happens when you move the pharmacy benefit to try to save money for your state, you harm the 340B program. So just recently in New York and in California, New York in particular, we fought back so hard. We got a 2-year delay of what we think was a very bad idea that would have hurt the 340B program. California is in the midst of litigation and other issues. So neither of those states have effectuated a carve out, which we think would be dangerous, or we know would be dangerous to the 340B program. So our foes are many. The attacks keep coming. And again, all the more reason for us as a grassroots organization to say, no, you got to protect 340B. And the speakers are going to do a far better job than I will of talking about why it's so important to their particular communities. So Rhiannon, go ahead. Do you want to introduce the panel? And I will sign off. Thanks.
That sounds good. We have 3 amazing speakers today. We have Nicole, Fiorella, and Renee. Renee was having some technical difficulties, but I think we have her back, so hopefully we'll keep her on. We've done about 10 of these webinars without any issues, so apparently we were due. We're thankful that you're still hanging with us. So to start today, we're going to start with Nicole. She is a pharmacy program administrator at Cornerstone Care Community Health, and we'll have her talk a little bit about how 340B helps Cornerstone.
Thank you. Good morning, everyone. So at Cornerstone Care, in my time at Cornerstone, I've been here for 5 years. I've seen Cornerstone Care grow from having 9 sites to now having 14 sites, including the mobile services. So with our pharmacy program, we have a sliding fee program for pharmacy services, providing low-cost medications for high-risk, high-need patients. We also have a prescription assistance program, sort of like what the manufacturers do, but it's an in-house program, and we only have contract pharmacy. We rely solely on our contract pharmacies and those relationships in the community for those services. Also, I've seen the expansion in the last few years in high need, high risk areas. 2 offices in the urban area outside of Pittsburgh. We built a dental and a medical office. We've done expansions in some of our other offices. And we also changed our scope last year to include optometry. So we have 3 new sites that are optometry offices. With our mobile services, I'm really proud of what the program does to help the mobile services. Our mobile unit provides medical, dental, women's health. They go into local school districts and colleges. We're mainly in rural areas, also in urban, but mostly rural. So those local school districts and colleges, one of the biggest barrier to care that we have is transportation for our communities. So the mobile unit has done an amazing job in serving our communities. We also have outreach and social services. And in the middle of a pandemic, the mobile unit did amazing things with the COVID testing and vaccinations. We serve about 20,000 patients a year. Like I said, we went from 9 locations to 14. And the program is crucial to serving our communities and reaching our mission as a community health center.
Have you, Nicole, I really appreciate all of the examples. I especially am interested in, have you seen the 340B program be of more use during the pandemic as far as, more people coming through your doors, more need in the community?
So there's definitely been more need. The program has helped us through COVID-19, like I said, with mainly our mobile unit and outreach. But I'd say the biggest thing is last year at this time, our dental services were down. We shut the doors on those clinics. And the 340B program, we wouldn't have had our doors open. We were down 60% encounter rate. So through this pandemic, it has really helped us just keep the doors open. And the vaccine efforts, we stayed open. I think there was a couple days that we were open till 9-10 o'clock at night taking patients for the vaccination efforts. So those savings really helped us keep the doors open and be able to not only expand, but like I said, just keep the doors open, really.
Yeah.
But the other programs that I mentioned with our sliding fee for pharmacy services, our prescription assistance program, it's more like a copay assistance program. And in the middle of a pandemic when everybody was struggling, I don't know how many people came through my office, so desperate need for help. And once they realized we had programs that would assist them with their medications, I mean, I can't say enough good about what this does for our patients and our communities, along as us also. It really helps our health center. And like I said, in the middle of a pandemic, it came, it helped offset our bottom line. It really did. So So we're very thankful to be able to have this program, even in the middle of a pandemic with the pushback from the manufacturers, like Peggy was saying. But we kind of persevered and just kind of changed some things. It was, a struggle going through the pandemic with the manufacturers' pushbacks, trying to find alternative medications for our patients that were on our sliding fee or copay assistance programs. But I mean, it does so much good for our patients and our health centers.
Yeah. We have a question. Could you talk specifically about how it's helped with your mobile health initiative and how that's kind of been able to be, supported through the 340B program?
Yeah, so our mobile unit is funded by the 340B program. Just this year, we've increased 1,000 new patients.
Wow.
Our outreach department sets up different events. They go into our local school districts. They provide dental health, to the local schools. They do physicals at the local schools. They also set up at college fairs and go into colleges and do STD testing and women's health. And also we were able to take that unit and set up mobile vaccine sites and testing. And also we're actually been saving to buy a second unit. So,
Oh, wow.
So we have one unit now, and we kind of allocate the time between dental and medical.
Mm-hmm.
So we're hoping here by the end of the year to have enough money saved to where we have 2 units, one for just dental and then one for medical, so we can actually expand our services. It also has allowed us to move a little bit into the West Virginia area because we're right on the line.
Mm-hmm.
So the mobile unit we are sub-grantees of Adagio Health. So we are in West Virginia doing family planning services and hopefully to expand that services as well. Our outreach and mobile unit, when I first started, was 4 people. Now we've grown to about 21 in that department. So it really has helped us expand to reach more patients.
That's amazing. Well, thanks, Nicole.
Oh,
That was
thank you.
awesome. All right. Next up, we have Renee. Renee, do we have you on? Nope, I think we might, Renee. I think we might have lost her. So we're just going to go through to Fiorella. This is Renee's Porter Hospital. Am I muted? Nope. I don't have you muted, Renee. Okay, let's go through to Fiorella while we figure out how to get some audio from Renee. Fiorella is a 340B pharmacy program manager at St. Joseph's University Medical Center. Thanks, Fiorella, for being here. I'm going to go through to your slides. Are you ready?
Yes, thank you for having me. So hi, everyone. My name is Fiorella Vera. I'm the 340B pharmacy program manager for St. Joseph's Health. St. Joseph's is located in Paterson, New Jersey. That's our main site. That's a trauma center and as well as a children's hospital that houses around 651 adult and pediatric beds. We also have an additional hospital in Wayne, New Jersey, that houses about 229 beds. It's an acute care community hospital. We also have another rehab center located in Cedar Grove that houses 151 beds. In addition to that, we have more than 30 North Jersey community-based facilities. And that robust network of entities and service sites allows us to be a disproportionate share hospital. And we've been a disproportionate share hospital since 2002. So we've been part of the program since then. And currently we have 52 eligible 340B sites. So I really wanted to talk about our mission and how it works in accordance with the 340B program as a whole. Quickly, our St. Joseph's Health is a healing ministry of the Catholic Church, sponsored by the Sisters of Charity of St. Elizabeth. We are committed to provide exceptional quality of care, which sustains and improves both individual and community health, with a special concern for those who are poor, vulnerable, and underserved. So, as was previously mentioned, the 340B program as aim and goal is really to enable covered entities to stretch their scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. So it's really important to recognize how synonymous the 340B program aim is to our mission, essentially providing a vital tool to accomplishing our objective. So by using the 340B pharmacy program, we're really close and it really helps our mission as a whole. And just to share some figures with you, I think it's really important to see the numbers and the facts behind how the 340B program impacts our organization. We have started 3 pharmacy program initiatives with the help of the 340B program. Number 1 is a 90-day discharge prescription program. So we actually supply free of charge to our uninsured and underinsured patients a 90-day supply upon discharge of whatever medication that is prescribed by the doctor until they're able to see a local provider at one of our 340B eligible sites. In addition, for number 2, we have a 340B uninsured prescription program. So we actually share our 340B cost and our 340B savings with our patients by allowing them to either get the 340B discount up front by filling out one of our contract pharmacies, or we cover their meds completely. So as you can see, in 2020, we were able to fill around 15,506 uninsured prescriptions. So we do have a lot of patients that are utilizing this program right now. Either they're getting their medication free of cost or they're paying a small amount based on the 340B price. In 2021, we've already filled up to 7,328 uninsured prescriptions. And so we are already on the track to surpass last year's number. And I think it's really important how our patients are utilizing this. As you can see, I included the top 5 drugs by claim. So we're seeing that Levemir, blood pressure, and high cholesterol maintenance drugs are the top 5. These are drugs that our patients use every single day. They need to maintain their health. So by giving them these free drugs and increasing their access, we've really been impacting our community health overall successfully. And lastly, sorry.
Oops, sorry, I'll go back.
And lastly, just our in-house purchasing. So we use the 2 aspects of the 340B program, one that happens outside at our contract pharmacies and one that happens within the hospital through our in-house purchasing and our inpatient and outpatient purchasing within the hospital. And we've seen a lot of savings in that way. That savings was really vital during the COVID-19 pandemic because we were able to stockpile and we were able to have those drugs readily available for our patients. It really helped us with our expenses overall because we're able to get that 340B price. All of the savings that we did obtain during that time, we were able to then use for our COVID-19 stock. So without that program, it really would have been hard to maintain and control our expenses during that time. And just overall, what we've seen really the impact of the 340B program here at St. Joseph's Health has been seen through our reduced readmission rates for that 90-day supply. We've really seen our patients have less ER visits and been able to actually continue their treatment at our other 340B eligible sites. In addition, we've improved treatment adherence. By increasing access, the 340B program really ensures that our patients are taking their meds when they need to, that they have those meds readily available. So that means that they're maintaining their health in a better way. In addition, we've increased access to specialty prescriptions. As we all know, specialty prescriptions are the highest cost drugs for most of our patients. That's the biggest barrier for a lot of our patients here, especially when they're uninsured. So the 340B program allows them to have access to the specialty prescriptions as they need it. In general, the savings for the hospital has really been monumental through the 340B program, especially for in-house purchasing. Since we are utilizing the 340B pricing for our outpatient sites and for our outpatient dispenses, we've seen a lot of savings for that we've been able to put into more comprehensive care services overall. And that's it. Thank you so much.
That's wonderful. So Fiorella, I'm curious, I love that you listed, some of the most impactful. What would you say is the single most impactful way that 340B helped your community through St. Joe's?
I would say definitely just access and treatment adherence for our patients. So we've seen less comorbidities, we've seen less complications for our patients. Like I mentioned, that readmission rates have dropped because they've been able to maintain, for example, their blood sugar and their diabetic treatment throughout the time that they're seeing their patients, because otherwise they would not be able to maintain that without their diabetes medication, and they wouldn't be able to get that diabetes medication without the 340B program.
Yeah, just simple access to care really is what 340B is providing.
And we actually have a high percentage of uninsured, underinsured, as well as charity care patients. So we do take a lot of charity care for our patients, and that was one of their biggest barriers, was medication access.
Yeah. Well, that's great. Thank you so much. That was wonderful. We're going to go ahead and check back in with Renee. Renee, can you hear us or speak to us? Okay, I don't think that Renee can speak to us, but she's going to actually call me and we're going to get her on the phone here. While
Rhiannon, I'm getting her on the phone.
Oh, you're getting her. Okay, great.
Okay, let's try this.
Hello.
Can you hear Renee?
Yes.
Can everybody hear me?
Yes, we can hear you, Renee. Thank you.
Okay.
Go ahead.
Even with 340B savings, we can't afford microphones for the computers. So, I will tell you a little bit about Porter Hospital. We are a critical access hospital in Middlebury, Vermont. That means we became eligible for the 340B program in 2010, and it has been helping us to keep our doors open since then. We are the only community hospital in Addison County. Our nearest healthcare wise are 40 miles to our north and 40 miles to our south. There's a big old lake and big old mountains sandwiching us on the other side. So if you're not familiar with Vermont, the summary is our patients would have very difficult time seeking healthcare and would have to travel a great distance if we were not here. In our last fiscal year, 340B saved us about $3.2 million in drug expenditures. We provided over $800,000 in uncompensated care. Our community benefit was 9.31% of our expenses, and we provided over $200,000 worth of support to the Open Door Clinic, which is a clinic for the uninsured here in our community. They service a lot of migrant farm workers and others as well. Some specific things that we have done with our 340B savings over the years that we are particularly proud of. We started a few years ago when many people may recall the price of EpiPens going through the roof. There's this life-saving medication that suddenly costs hundreds and hundreds of dollars. We began giving those pens away for free. Since this document was created, I think we've given away over 1,000 pens. So life-saving medication at no expense to our patients. We offer, as some of the other panelists discussed, the pharmacy assistance program, so covering co-pays and deductibles, particularly for high-cost medications like inhalers, insulin, anticoagulants, medications that if patients are not compliant with, lead to hospitalization and increased healthcare costs. We also offer free pediatric inhalers. This was a really grassroots effort. Some of our pediatricians came to me and said, we run into issues. We have late office hours to accommodate our patients, but a lot of the community pharmacies in our small town are not open as late as our practice. And we see kids in the practice, late in the evening. They maybe are having an asthma exacerbation or have a pretty bad upper respiratory infection, and we need to get them an inhaler. And if they don't get the inhaler that night, they may end up in the emergency department. And that's going to cost the entire health system far more than if we could just give them an inhaler. So we started doing that in those specific situations when it may, it's the right thing to do for the patient, and it's going to save healthcare dollars as well. We've been able to provide free antibiotics for STD treatment and a veggie prescription program providing produce for food insecure individuals in our community. So those are some of the specifics. There's been a lot of general things that we have been able to do with this savings as well. We've expanded palliative care options so that patients and their families at the nearing the end of life have a more holistic option for care. We've expanded team-based care, which is an initiative to drive quality and reduce costs by providing behavioral health experts, social workers, dietitians, and most recently, we've added a pharmacist right to our primary care team, so patients can receive all of those services within the comfort of their primary care office. Most of our capital expenditures would not be possible without our 340B savings. So if we need a new ultrasound machine, chances are it's been 340B savings that have played a role in being able to update that equipment. You heard Nicole say that this savings keeps our doors open, and that really resonated with me. And never has it resonated more than in the past 12 months. I wanted to talk just briefly about what we've been able to do in response to the global pandemic. So for those of you who are close to healthcare, it probably sounds familiar when I tell you we shut down for all elective surgeries and saw decreased elective volumes throughout our organization last March and April. And that was like turning off the spigot to our revenue stream. Nonetheless, we created a temporary inpatient unit on our ambulatory surgery unit to accommodate COVID surge. Our surgical technicians were trained to sew gowns and masks so that they wouldn't have to be furloughed. We erected a 10,000 square foot tent in our parking lot to accommodate overflow from our emergency department. Wow. We tripled within a week. It was really quite remarkable. Within a week, our plant ops department was able to triple our capacity for negative pressure isolation rooms and install ultraviolet air sterilization systems. We put up a drive-through testing site and stood up an acute respiratory clinic to provide safe care for those individuals who may be COVID positive and keep them isolated from non-positive individuals. And, the driving factor behind all of these efforts was really ingenuity and innovation, but none of it would have been possible without the savings of 340B. There's obviously cost associated with all of this work, and it was done at a time when we had lost millions in revenue. Nonetheless, we pushed forward and did what needed to be done to take care of the community. You heard Peggy talk about the hits that the pharmaceutical industry tried to make to 340B last fall. And I feel that came at a time when we were all hanging on by our fingernails and really maybe had let our guard down a little bit. Those reductions that the pharmaceutical industry attempted to make to 340B, we anticipated that was going to impact quarter by $1.7 million. So over half of our 340B savings potentially would have been lost by those actions of the pharmaceutical industry. So, my question would be, which program should we cut? Is it the team-based care that's intended to drive quality and cut expenses? Is it copay assistance for vulnerable retirees? Should we turn away COVID patients because we don't have the means or the space to treat them? Also, some Fortune 500 pharmaceutical companies can have an extra $1.7 million for their shareholders. This is an industry, again, Peggy did a great job at highlighting this, but this is an industry that spent over $300 million on lobbying in 2020.
Mhm.
They spent 9.53 billion with a B on advertising in 2020.
Mhm.
Now, it might sound like I'm throwing the pharmaceutical industry under the bus, and before we throw the bus in reverse and back over them a few times, I'll say that I've been really proud of the pharmaceutical industry and their response to the pandemic as well, with the vaccines and treatments that we rapidly received or rapidly developed. We're about to put this pandemic behind us, thank God. And so my hope is that we can continue to collaborate. And as we get past the crisis of the COVID pandemic, that we can refocus on the crisis of rapidly growing healthcare costs and recognize that 340B plays an exceptional, extraordinary, vital role to containing healthcare costs. And I will pause there.
Beautifully said.
That's amazing. That's amazing, Renee. I have to say, like I said, we've done several of these. I mean, we probably have done 10 of these. But this is always my favorite part, hearing from the panelists, hearing from Fiorella, hearing from Nicole, hearing from Renee, because I'm just absolutely, and even more, in the last, like you said, Renee, in the last 12 months, absolutely gobsmacked and in awe of what providers have been doing, and how 340B has supported them in responding to this unprecedented pandemic that we've had. And so I'm really in awe of all three of you. I'm thankful that you were here and that you're able to share your story. And I just want to kind of give you maybe a little silent round of applause. So thank you for all you've done. Thank you for everything you've done the last 12 months. Thank you for being here and speaking to us today.
Yeah, and if I could jump in, Rhiannon, beautifully said. Are you telling your patients and your communities about, you are today in this
Yeah.
webinar, but all three of you, are you making sure your communities know about this? I presume with your work with CV340B, you have a commitment to that, but we're trying to also inspire others. Don't hide your light under a bushel basket. Make sure you're telling everybody how great the work is that you're doing for your communities. And I know sometimes that's hard for healthcare providers who just knuckle down and do it and get the job done. But in order to protect this program, our greatest goal and effort and mission here is to make sure we're singing it loud and proud so that communities know they have to fight for this to keep it.
Yeah, absolutely. So thank you all so much for your presentations. This is really the bread and butter of what we're doing here, is talking to your communities about what 340B is doing. So thank you for that. We're going to wrap up here in the next 5 minutes with a little bit of advocacy, kind of a nice segue for us. 340B helps the Northeast. We have several of these shareable infographics to help you at home talk about 340B with your community. And so this we actually turned into a postcard pre-COVID, and we're able to send you those postcards if you want to hand them out to your patients or your community members. It really goes through in very layman's language. 340B helps nonprofit healthcare providers provide more services, serve patients regardless of their ability to pay, give you the care you need when you need it, and it's all done without taxpayer dollars. On the back, there's a little explanation and a place where you can fill in information if you want to. CV340B has several ways that you can get involved. We, on our website, under our advocacy page and our Get Involved page, we have a form that you can fill out and tell us, would you be interested in writing a letter to the editor, or signing a petition, or hosting an event, telling your story, being a social media ambassador, leading a community voices group, or telling a friend. Some of the kind of high level things or the easy things that we can do is sign our petition. We have a Dear Policymakers petition on our website. We also have a faith-based leader petition on our website. So if you're a member of the faith-based community, if you consider yourself a leader in that community, feel free to hop over to our website and sign our faith-based sign-on letter. In all of this, we also have Tell Your Story. We're developing a platform called 340B Stories, where we will record providers, patients, community members talking about the good that 340B does. So that's another thing that you can do in, in just 5 minutes. Again, we have a ton of resources on our website. And as you can see, we have, these are postcards that can go out to you. This is kind of a flyer that can go up at your provider center, at your community center, at your church. These are all free to download at CV340B.com. You can download and get them printed out. We have a sample letter to the editor and a sample email to Congress. Something that we've discovered in the last few months is that this 340B world has kind of moved a little bit into the States, a lot into the States, I'm going to say. Hopefully Peggy agrees. So something that we're doing as sessions are ending in the States is we're educating our legislators, our state legislators, on what 340B is. Now, CV340B is a 501c3. We cannot advocate for any specific legislation, but what we can do is educate our legislators on the importance of 340B and how it helps us in the Northeast. We have, if you haven't already seen or if you haven't already liked, we have our website. So definitely go take a quick look on there. We have our Twitter at cv340b.com. We have our Facebook and our LinkedIn. So please give us a like and share our content if you have the time or if you have any of those platforms. We had a question in the Q&A. Is the introductory video about 340B publicly available online? It is. If you do kind of what I did and Google let 340B, it will come up in your YouTube. And what we can do is send it out to all of our participants. The Let 340B campaign is kind of a sister organization to us. They have a lot of great resources as well, so feel free to kind of give them a poke around. Let's see, do I have another one? I answered that one. If you have any questions, concerns, thoughts, please email me. Again, I want to say for the final time, thank you for bearing with us today. I think that all of our chips came in and we were due for some technical difficulties. So we really appreciate you. We appreciate you being here. And Peggy, anything else? You're on mute.
Fantastic timing to wrap this up because I've got a 105-pound dog who now needs my attention. So.
Awesome. Okay, guys, thank you so much for everything. I hope that you have a great rest of your day and we will chat more. Thank you so much.
Thank you all. Great job.
Thanks, everyone.